Claire Fox from the LA Food Policy Council. Public comment will be at the end of this particular item. At the end of item 1, we'll take public comment.
Is there a clicker? Oh, there it is. Hi, good evening, commissioners. Thank you so much for having me. Here to share the work of the Los Angeles Food Policy Council and to present to you some recommendations and some ideas for how together we can improve the health of Angelenos through policy change and community development that supports everyone's ability to eat nutritious food. As was mentioned, my name is Claire Fox. I'm the Executive Director of the Los Angeles Food Policy Council. We were founded in 2011 as an independent nonprofit by the City of Los Angeles and a collaborative of leaders and experts representing the food system from farm to fork and beyond. And our mission is to facilitate multi-sector collaboration to ensure that all Angelenos can enjoy good food, and we define that as healthy, nutritious, safe, affordable, as well as grown in a sustainable and ethical manner. And I'd like to just sort of quickly shout out to our team. We have a couple members, we have even more than I thought. We have 4 members of our team here: Esther Park, Aisha Seiler, Daniel Rizikbear, and Stephanie Gomez. So just wanted to make sure to introduce them as well. So in this presentation, I would like to review for you some of the highlights of food policies that the city has already adopted, so you get an update on where we're at with those, some current proposals that are under consideration, and also some ideas for where I think we might be able to go in the future. And my focus today is really going to be on efforts that seek to transform neighborhood food environments. We're involved in a lot of different efforts, but I wanted to focus in that way. So first is the good food purchasing policy. The city made history when it adopted this policy in 2012. The city committed to ensuring that 15% of its own food purchases would meet a minimum of standards with regards to nutrition, environmental sustainability, fair labor practices, animal welfare, and investing in our local food economy. This policy applies to all departments that buy $10,000 worth of food annually. Most notably, this involves the Department of Aging, which serves approximately 1.6 million meals annually, if you can believe that, through senior service centers and Meals on Wheels programs. Also, the Department of Recreation and Parks has made some pretty good headway with this policy for its summer lunch program, which is a partnership with LA Unified School District, and that serves about 200,000 meals to young people in parks for free every summer. And just this last fall, there was a new council motion calling on the city's proprietary departments, including Los Angeles World Airports, the Harbor, DWP, to also participate in the good food purchasing policy. So though we do have some ways to go in terms of reaching that baseline of standards, we should be very proud of the city of LA for adopting what, as far as we know, is the nation's most comprehensive food procurement policy, and the only one that includes any standards around fair labor. So, you know, we often talk about voting with our fork as consumers. The city has made a really significant pledge in voting with its own multi-million-dollar fork with this policy. Some of the ways that we acknowledge the participating departments every year is through Food Day, where City Council acknowledges the efforts of the departments and also their food vendors. So I'm going to talk a little bit about urban agriculture. Some of you may be familiar with the story of Ron Finley. He is an artist and a gardener in South Central Los Angeles who is cited by the city for planting food in the parkways outside his home, and that's that little strip of land between the sidewalk and the street. Several other gardeners also faced penalties from the city. This was a few years ago, until City Council took action to update the city's municipal code so that edible gardens are now allowed in parkways. And what's notable here is that growing foods in neighborhoods has been identified as a way to improve access to healthy food, to supplement food budgets, especially for low-income families, to create green and open space, capture stormwater, clean soil, etc. But, as I'm sure you can imagine, access to land and land security are ongoing challenges for food growers in a dense urban environment. So Though the parkway may seem like just a little strip of land, in many neighborhoods that's all that's available. And so for urban growers in LA, this was seen as a real victory. And I'll talk a little bit more about some updates on urban ag policy in a minute. As we also know, I hope you're familiar that many low-income neighborhoods lack adequate grocery retail services, but instead are home to many small neighborhood stores like liquor stores, carnicerias, other convenience stores. The LA Food Policy Council invests in those stores and store owners already operating in food desert neighborhoods to help them successfully sell healthy and fresh food. This program is supported in part by the City of Los Angeles Economic and Workforce Development Department through Community Development Block Grants, as well as LA County Department of Public Health. Yes, so, I'm sorry, my notes are out of order here. These are some of the initiatives that are already underway, and now what I'd like to do is share with you some of the proposals that are currently being considered by City Council. Sorry, my notes were out of order there. Just last week, the LA Times editorial board wrote a piece, and I'm going to quote here, "Los Angeles does love its farmers markets, but not all Angelinos can use them. Of the approximately 60 certified markets in Los Angeles, only about half accept the modern version of food stamps, electronic benefit transfer cards, or EBT. There's something terribly wrong when Jack in the Box and corner liquor stores eagerly accept EBT, but a farmer's market does not." End quote. So this is an issue that LAFPC and our partners have worked on for some time. We were very pleased to see in December, Councilmember Jose Huizar introduced a motion exploring the ways that the city could require EBT at all farmers markets. So we expect a report back on that motion next month. And in May, LA Food Policy Council has partnered with the mayor's office as well as USDA to do an EBT sign-up day for farmers market managers, and that will be for CalFresh Awareness Month on May 17th. You are all more than welcome to attend. I'm going to skip that. So the policy focus right now for urban agriculture is the local adoption of an urban agriculture incentives program that provides a tax reduction for property owners of vacant parcels who make land available to community gardens, urban farms, or other agricultural education projects. The LA County Board of Supervisors is slated to vote on this initiative and create the program on the county side next month. On the city side, LA City Council also has an outstanding proposal to create a citywide program. So we're hopeful that this new incentive will be a way to activate vacant lots that otherwise do not serve the community and turn them into green spaces that feed people. Another opportunity for expanding access to fresh food is by creating a permit system for mobile food vendors to sell on city sidewalks. The city is considering an ordinance to allow sidewalk vending under certain conditions. The LA Food Policy Council recommends that this program also include incentives for fresh food vendors to sell in areas with limited healthy food options. So, with my remaining minutes, I'd like to present to you 3 ideas for your consideration as you endeavor into your strategic planning and your goal setting for the year. As you can see, we have more work to do on even those policies that are on the books, but there's not a lack of good work that needs to be done. So I want to seed some ideas with you and hopefully inspire your support. First idea is, I mentioned the Good Food Purchasing Policy, in which the city committed to buy and serve food that is local, sustainable, fair, humane, and nutritious. Of the participating departments, the Department of Aging reaches one of our most economically vulnerable and food insecure populations, senior citizens. And this population is expected to double in the next 10 years. And so too will their nutrition, food security, and health needs. So we see a really huge opportunity for the Department of Aging to be a leader on the Good Food Purchasing Policy by improving the quality and integrity of meals being served to seniors and even expanding those programs. My second idea for you is that the city should create a market match fund to increase participation of EBT recipients at farmers markets. So for those of you who aren't familiar, Market Match is a program that provides financial incentives for EBT sales at farmers markets. It works in a number of different ways across the country. In other parts of the country, it's called Double Your Bucks. Here in LA County, we have some funding from First 5 LA for a market match program that provides a dollar-for-dollar match at farmers markets. So in other words, if I'm an EBT customer shopping at a farmers market that participates in market match, and I buy, let's say, $10 worth of veggies, I could turn that $10 into $20. And it is capped at $10, but it's a pretty significant match. This program has proven effective at driving up sales overall at farmers markets. Some preliminary numbers is for LA County farmers markets is at up to 40% sales increase as a result of market match. And so this is good for the farmers. Obviously, it's good for the farmers market itself, particularly if it is in a low-income neighborhood. It helps support the sustainability of the market. And it's been proven as a way to support low-income participation at farmers markets even after the match is done. So I'd like to, I think that there's a great opportunity there for the city to consider creating its own market match fund to support low-income Angelenos buying fresh and local food at farmers markets. And then last but not least, we believe that the city should establish a program to attract and sustain healthy food retail in low-income neighborhoods that have limited fresh food options. You may be familiar with Chef Roy Choi's new healthy fast food venue in Watts called Local. We know that the City Council office and the Mayor's office played their role in supporting that, which is fantastic. What can we do to create a citywide approach to foster healthy food retail in areas like South LA, Boyle Heights, the Northeast San Fernando Valley? We can look to the Health Atlas, which was created by the city planning department through the Plan for a Healthy LA to serve as a guide for where to prioritize those incentives. We know we need dedicated city staff who can drive economic development projects and bundle incentives across a variety of different departments. That will be essential. So the way we look at this is somewhat through the lens of a program that the CRA had launched in the last couple years of its existence to do this work of really attracting new retailers and sustaining their business in low-income areas. Well, we don't have the CRA anymore, so now we look to the city for the next iteration of supporting fresh food businesses in high-need areas. And it really will take a concerted and diligent effort, and we believe that that's a very essential part of tackling health disparities in Los Angeles. So that is my presentation. Thank you so much for the opportunity. You have my contact information here, and I am happy to answer any questions that you may have.
Great, thank you so much. Any questions from the commissioners?
Just one. Commissioner Sharp, just for purposes of microphone. Ms. Fox, thank you for joining us. It's been an honor to serve on the board of the Food Policy Council for many years, and to see such succinct and useful recommendations come forth is really helpful to us as a commission. We are intending to develop recommendations, plans for perhaps changes that the county could make as well to further enhance the health of residents in the city. And I was wondering if you believe, just as a broad brushstroke, that these same policy recommendations have roughly equivalent value to be achieved if adopted by the county departments as well.
I do. I absolutely do. And I think a good example is the EBT at farmers markets policy. The inquiry now is where and how does the city touch all farmers markets? We know that the city touches farmers markets when they apply for a street closure permit, but the county actually touches they certify farmers markets in the county. So I think when we're talking about mechanisms for ensuring that all farmers markets require EBT, the county is a really critical partner in that. So that's just one example. But I think all of the things that we've talked about would apply as well.
I have a question. Yeah. Commissioner Vick, I live in Council District 8, and I noticed that in CD8 and CD10, I think in that general sort of where that border is right there, we lost a couple of grocery stores over the last few years. I think they were both Ralph's. Just wondering, along with all of this, that's absolutely awesome. I love Ron Finley. Whenever I see him, I don't even know him. I'm like, hey. Wondering if there's any work around getting grocery stores back into South LA. I know, like, for instance, there was a big push to get Fresh and Easy, which, of course, now is not even an issue, right? But on 52nd and Crenshaw, for instance. So just wondering if there's any discussion about just even getting full-service grocery stores back into some of the communities.
I mean, certainly among advocates and community stakeholders, that's an ongoing conversation. I think that's why I wanted to lift it up as a critical strategy, that there needs to be coordination across departments and there needs to be dedicated staff to drive that forward with the kind of capacity to project manage new grocery development in South LA and CD8 and CD10. The Healthy Neighborhood Market Network program that we run at the Food Policy Council is an attempt to invest in the existing food retail landscape, so working with those entrepreneurs that are already there. But certainly a mom and pop store will never be able to provide what a full service grocery store can provide. So it has to be a tandem strategy. And there was, as I mentioned, through the CRA, a program called Incentives for Market Retail, I think it was called, and where they bundled a variety of different economic development, planning, policy incentives, land use incentives, financial incentives together, and marketed it to major grocers. And that, I think, was a good way to go, and I think that's something that the city can look at again. Another opportunity we have is through the California Freshworks Fund, which is a statewide fund explicitly for incentivizing new grocery development in low-income neighborhoods. And they have funded, for example, the Northgate Gonzales at Slauson and Central. That was a Freshworks-funded project. And there's still financing available for those kind of projects. It's just a matter of finding the right operators who are willing, and then finding land and making sure that there's a match there. Thank you. Yeah.
Commissioner Mandel. So a concern I have is that with the mom and pop shops that actually do provide a great service for most of the communities, most of the employees in those are not earning a significant living wage, but they can afford to live in their local community. With the alterations in the wage laws that are going to happen in Los Angeles, concern I have is, in one hand, we're trying to do a good thing. On the other hand, we're actually going to put those small businesses partially out of business or totally out of business, causing some communities to have more of an adverse impact. Are you guys looking into the impact going forward of the living wage laws that we've passed and the impact on small businesses and communities that are food deserts?
No, we haven't looked at that deeply. A lot of our approach to working with neighborhood markets, corner store owners, is to support their capacity to operationalize fresh and healthy food and make money doing so. So we look at the business modeling around it so that it is sustainable for the long term. And we want to set them up for success, not failure, right? So we're looking to build their skills as small business owners, which is why it's wonderful that our partner in this is the Economic and Workforce Development Department, and that this is coming through community development block grant money to support micro enterprise assistance, because we know that that's important. We can't just parachute in and have baskets of fruit at the checkout counter, and then we come back and 6 months later it's not working. And it's hard. It's hard to make money selling fresh food, but there are strategies for that. And so what we do is leverage our relationships in food industry, people who are experts in this area at a larger scale, to help smaller business owners understand what they're able to do in terms of their long-term profitability around fresh food. So the question of how the raise in wages will impact these small businesses, we haven't looked closely at.
Okay, thank you. Commissioner Arreola, thank you very much for the information. I just wondered if you have reached out to the WIC program, Women, Infant, and Children, because I know that I believe that some of their food groups are, or coupons are accepted at some farmers markets, or at least partnered with them to find out what's going on.
Absolutely, yeah. WIC has their own farmers market voucher program. And they do WIC enrollment at farmers markets. It's a very successful program. It basically sells out every year. They run out of the vouchers. And the reason why I raise Market Match as an opportunity for the city is because, the funder can inform the terms of how Market Match works. So for example, First 5 LA, their interest is families with young children 0 to 5. Obviously, that would also cover the WIC population. Right. But as I pointed out, we have a rising elder population that also has food security needs. And unfortunately, Market Match doesn't necessarily support their participation at farmers markets. So if the city had its own Market Match fund and attracted funders to support that, a diversity of funders, we're able to meet the needs of a multitude of vulnerable communities and support their buying and participation at farmers markets. So I think WIC is a great example of how we can broaden the horizon of who gets to participate in programs like Market Match, if the city was the driver of it.
Thank you.
You had mentioned that CalFresh Awareness Month, Carlin Andrews-Taylor. You had mentioned that the CalFresh Awareness Month was May. Is it throughout the whole month, or you're doing a particular day to get people more signed up for it?
It's the whole month, and LA County Department of Social Services, which is the program that administers CalFresh locally, does a number of sign-up days throughout the month. They have their mobile units that go out and sign people up. We actually have massive under-enrollment in the CalFresh program here in LA County, so I'd identify that as another opportunity for both the city and the county, because there's, over 50% of LA County residents that could benefit from CalFresh are not enrolling in the program. So that's where CalFresh Awareness Month comes in, is to really raise the visibility of this. Our event on May 17th is targeted at farmers market managers, and USDA is hosting these events across the country, actually, to help farmers market managers get their EBT equipment within a matter of hours. So they're walking out the door ready to go. Sometimes it takes 45 to 90 days for their application to be processed, but with these events, they're getting them processed in a couple of hours. So right now, what we know is that 34 markets, farmers markets in the city of LA, either do not accept EBT or they're unverified. So we're really hoping to bring that number to 0 by the end of this year.
Excellent, thank you.
Any other questions? I have a quick question. Other than your EBT program, the farmers market, are there any programs, or is there any emphasis at all on, just specifically on the homeless population?
What do you talk about what Steve's up to?
Steve?
The rooftop gardening with LA Can.
I don't know as much about that, actually. So maybe you could.
Well, the question was to Claire, but I have some information I'm happy to share about some specific efforts to target the food security needs of those both in the downtown community as well as homeless throughout the city. There are some very creative strategies to use gardening as a therapeutic tool and as a food generation tool. There's several funded projects that are exciting and worth increasing. The main challenge facing that population is that Central City East has so few adequate food outlets that even with the EBT card, folks are dependent on convenience and liquor stores. It's a terrible challenge.
And actually, the EBT at farmers markets policy comes out of organizing that LA Community Action Network has done for some years in the downtown area with the homeless population. And for a long time, downtown farmers markets did not accept EBT, but thanks to their organizing, they now do. Many of them do. And now we're sort of looking at how we could broaden that to the rest of the city. So that's as much as I know. I would point to LA Community Action Network as an amazing resource on that.
Great. Any other questions? Okay, thank you so much.
Thank you.
Thank you for coming.
Okay, our next speaker is Dr. Benjamin Schwartz, who is the Deputy Chief of the Acute Community Disease Control Program at Los Angeles County Department of Health, and he's going to speak on the Zika virus and health concerns related to that. Thank you.
Thank you for your interest in hearing about Zika virus, which is an emerging disease risk that is affecting people throughout the United States as well as the countries that are infected where there is ongoing transmission of Zika virus. So what I'd like to do in this presentation is to begin by talking about the transmission, the epidemiology, and the health impacts of Zika virus. Then to share some guidance for assessment and testing of patients with possible Zika infection, present our surveillance strategies and some of the results from that surveillance, and then finally to discuss approaches to prevent infection among travelers and also to reduce the risk of transmission locally. So we'll start by looking a little bit at the epidemiology and transmission of this infection. Zika virus was first identified in 1947 from a monkey in Uganda in the Zika forest. It is a virus that is closely related to other viruses that cause diseases that occur here, such as West Nile virus, as well as tropical diseases like dengue or chikungunya that can be imported into Los Angeles. The virus is transmitted to people by Aedes species mosquitoes, such as Aedes aegypti, and shown in the map on the bottom is the distribution of this Aedes aegypti mosquito, which includes most of the tropical and subtropical regions, as well as the southern United States and southern California. Before 2007, there were only sporadic cases of Zika virus infection that had been identified from Africa and Southeast Asia. But then in 2007, a large outbreak occurred on an island in the Pacific. And subsequently, between 2013 and 2015, there was a large outbreak in French Polynesia and on several other Pacific islands. In 2015, an outbreak began in northern Brazil, which currently has caused over 1 million cases, and subsequently there has been widespread outbreaks that have occurred throughout the Americas. Currently, 31 countries and territories in the Americas are affected, as well as 5 Pacific island chains and the Cape Verde Islands off the west coast of Africa. And this distribution continues to expand. And so to see the most current information, there are a list of countries that are affected on our Los Angeles County Department of Public Health website. Transmission is primarily from mosquitoes to humans, and then when a person is infected and has the virus in their blood, they can then transmit it back to an uninfected mosquito if they get bit. So infected people are viremic. In other words, they have the virus in their blood for about a week, during which time they can infect a mosquito if that mosquito bites them. But the other modes of transmission are the ones that are raising the most concern, and most importantly, intrauterine and intrapartum transmission, in other words, from a pregnant woman to her unborn baby. There is also some evidence of sexual transmission, and I'll talk both about the intrauterine and sexual transmission a bit more. There has been transfusion-associated cases, again, because the virus is in the blood. If you donate blood while you're viremic and then someone else gets that blood, they may become infected. And there also has been spread of the virus in laboratories. In addition, the virus may be found in urine, saliva, and breast milk, but there has never been evidence of transmission from those fluids. Sexual transmission is an increasing concern. There have been 2 cases reported in the medical literature, and there are 6 cases from February of this year that have been reported by the Centers for Disease Control and Prevention as being confirmed or probable cases, and other cases are currently being investigated. All of these came from men with or shortly after they had symptoms transmitting infection to their female partners. All reported unprotected vaginal intercourse, and the duration of Zika virus in the semen is currently unknown. All of the infected men had traveled to a Zika-affected country, and their partners had not. So the man had traveled to a country, brought back this infection, and then transmitted it to his partner who had not traveled and not been exposed. There are many things we don't know about the sexual transmission of Zika virus. Most importantly, we don't know how common this transmission may be. We also don't know how long the virus may be present in semen. There has been one case where it has been documented to be present for 63 days, but CDC is still gathering data on the distribution of duration for Zika in semen. We also don't know if asymptomatic men can transmit infection or if a woman can transmit infection to her sex partner. A number of different questions have been asked about transmission scenarios, and I'm showing some of these questions here just to share with you some of the complexities associated with this issue. One of the questions is, when can a woman become pregnant after she returns from a country that is affected by Zika virus? And because the incubation period, in other words, the asymptomatic period following infection may be up to 2 weeks, and then the period of having virus in her blood may be another week, we expect that it would be safe to become pregnant about a month after potential exposure in a country affected by Zika. Similarly, for donating blood, the guideline is to wait a month after returning from an area that is affected by Zika. But then we come to some of the more difficult questions that relate to sexual transmission. So what should a male traveler to a Zika-affected area do to prevent transmission to a pregnant partner? And the recommendation from CDC is to abstain from sex or to use condoms consistently for the entire duration of that pregnancy. Similarly, a question may come up, how long should a couple wait before becoming pregnant if the man has traveled to a Zika-affected area? And in fact, there are no recommendations. CDC has not addressed that issue, and we really need to get more data in terms of how long the virus may exist within semen in order to make a recommendation there. So the answer to that question is just not currently known. So let's move on to look at the issues around clinical illness, diagnosis, and management. About 80% of Zika infections are asymptomatic, meaning only 1 out of every 5 people who is infected will show any symptoms whatsoever. Those who do develop symptoms, those symptoms are generally mild and last less than a week. Hospitalization is rare, and there have been no deaths confirmed to be associated with Zika virus infection. The symptoms from 30 confirmed cases from Puerto Rico are shown in the table, and you can see that the most common symptoms include rash, muscle aches, joint aches, fever, eye pain, and so on. Guillain-Barre Syndrome, which is a neurologic syndrome that is associated with a temporary paralysis, may occur after infection, and that may occur after infection that has either been symptomatic or asymptomatic. So that's a post-infectious complication. I mentioned earlier a couple of the other viral infections, dengue and chikungunya, and these are viruses that are actually transmitted by the same mosquitoes with a similar ecology and which currently are circulating in the same areas, the same countries as Zika, so that you can imagine telling them apart may be very difficult. Laboratory testing is required to confirm Zika virus and to distinguish it from these other mosquito-borne infections. There is no specific therapy to treat somebody who is infected with Zika. Therefore, the treatment is supportive, it's rest, fluid, analgesics, antipyretics. A patient should avoid aspirin and nonsteroidal anti-inflammatory drugs like ibuprofen until dengue is ruled out in order to reduce the risk of hemorrhage that may be associated with that other infection. And vaccine development is ongoing, but a licensed product is likely several years away. Congenital infection really is the biggest concern with Zika. And in fact, this is the very first new infectious cause of serious congenital defects that has been identified in over 50 years. A series of 72 Zika-positive pregnant women has been reported from Rio de Janeiro in the New England Journal of Medicine just last week. All of the women in this cohort had symptomatic Zika infection, and 42 of these women had an ultrasound. Of those ultrasounds, 12, or 29%, were abnormal, and there were various abnormalities that were identified. In 2 cases, there were late fetal deaths occurring at 36 and 38 weeks of gestation. There was in utero growth restriction, in other words, babies that were very small symmetrically, but some of the babies had microcephaly, which is a small head that was isolated from normal growth otherwise. And then infants were identified who had cerebral calcification, in other words, calcium in their brains, as well as a handful of other abnormalities. Of 8 births that occurred in this cohort of women, only 2 of them have been totally normal. So what is microcephaly? It's a defect where the infant will have a significantly smaller than normal head circumference for sex and age, and it's associated with impaired brain growth. Laboratory studies have found the Zika virus in the fetal brain tissue by both laboratory testing for the virus as well as by electron microscopy, linking the infection to this complication. There was a series of 35 Brazilian infants who were enrolled in an embryopathy registry. This is a registry of infants born with this birth defect after Zika infection. And some of the findings from this were interesting. First, they found that women may be infected and pass on this congenital defect during any trimester of pregnancy. So while most of the risks seem to be associated with infection in the first trimester, congenital defects could also occur for women who are infected in the second or the third trimester. About 3/4 of the infants had normal birth weights and 1/4 did not. All of them in this registry had an abnormally small head circumference, and 18% had abnormal eye exams. And in a different study from Brazil, they found about 1/3 of them had abnormal eye exams. And 100% of the infants had abnormalities on neuroimaging studies. As with sexual transmission, there are many things we still don't know about the congenital defects associated with Zika infection. We don't know the full spectrum of defects and how common they are. We don't know the percent of infants who have defects by the specific type of defect and based on when the mother may have become infected, whether the risk to infants is associated with the severity of the maternal infection, or whether there are potential cofactors affecting risk or the type of defects that occur. The Centers for Disease Control has issued interim guidance for pregnant women, which emphasize getting tests so that pregnant women who travel to one of these countries where a Zika outbreak is ongoing should receive a laboratory test to rule out the presence of Zika infection. They also should get an ultrasound test to evaluate the fetus and, if any abnormalities are identified, to have specific follow-up. So what's happening with Zika virus surveillance and testing in Los Angeles? Currently, there is no local transmission of Zika in the United States, in the continental United States. So there is transmission in Puerto Rico as a U.S. territory, but not in the continental U.S. As of March 9th, there were 193 travel-associated cases in U.S. states and 173 cases in territories, most of them in Puerto Rico. In California, there were 13 confirmed cases in 2015 and 2016. They were reported from 8 counties, and all of them were travel-associated from various countries. As of March 10th, 4 of the confirmed cases were in Los Angeles County. 1 was in a pregnant woman. They had traveled to 2 countries in Central America, El Salvador or Honduras. All of the cases were symptomatic, and 1 of the 4 cases had residence in the city of LA. 43 Los Angeles County residents have been tested and confirmed negative, and there are many tests that are still pending from either CDC or from the California Department of Public Health. So who should be tested for Zika virus? Persons who traveled to affected countries and had symptoms consistent with Zika should be tested. Pregnant women, either symptomatic or asymptomatic, if there is evidence of fetal defects such as microcephaly or intracranial calcification, and then persons with Guillain-Barre Syndrome, that form of paralysis that I mentioned earlier. Tests would be sent through the public health laboratory here to the California Department of Public Health, and positive results confirmed at CDC. And our public health laboratory in LA County is bringing the tests online, so in a couple months we'll be able to do the testing locally. Cases are reported through a reporting form that is on our website, and that report is made at the same time that tests are sent to the laboratory for testing. And reports should be made by phone to our program for travelers who have evidence of fetal involvement, if the infant appears to be affected, or if there's possible sexual transmission or Guillain-Barre. It's important that we do community and provider outreach to educate the public about the risk associated with Zika, and also to inform people about approaches to preventing infection as well as local transmission. Our outreach has been led by the Department of Public Health Community Health Services Division, and we have a number of materials and presentations that we have made or that we distribute in various places. This information has been distributed so far to 40 cities in Los Angeles County, or to LA City Council district offices, to a number of healthcare provider offices and clinics, community organizations, as well as school systems. There also has been outreach to healthcare providers through the Los Angeles Health Alert Network, to providers at the Department of Health Services, and those serving Medi-Cal and My Health LA patients. And tomorrow morning, there is a webinar that will be at 8 o'clock in the morning, a time that I think is convenient for obstetricians before they see their patients. And almost 300 have signed up so far to listen to that webinar. We have produced a number of posters, warnings about the countries that are affected by Zika and how to prevent getting infected, as well as question and answer documents, and these are available in multiple languages. To prevent Zika infection, pregnant women should not travel to countries that are affected by Zika virus, so that they or their providers should be aware of those countries, know how to find that list on the CDC website or on our Department of Public Health website, and to defer travel to those areas. In addition, all persons, whether male or female, who travel to an affected country should take measures to reduce mosquito exposure. And this includes using insect repellent with an EPA-registered ingredient such as DEET. And it's important to note that these repellents are safe for use by pregnant women, and most also can be used on children older than 2 months. Wearing long sleeves and pants will also reduce the risk of mosquito bites, as will staying in places with air conditioning or screens. We know that we have the viral vector, the mosquito vector that can transmit Zika virus in Los Angeles. The Aedes aegypti is the primary vector, and Aedes albopictus, or the tiger mosquito, also may transmit this infection. These mosquitoes have peak feeding during the day, and they are aggressive. The mosquito and vector control districts have received multiple complaints by people who have been bitten multiple times during the day, and they do go out and investigate those complaints and have found these mosquitoes in those areas. What makes them difficult to eradicate is these mosquitoes lay their eggs in very small amounts of water around houses. The eggs may resist desiccation, so these areas may dry out, and the eggs can still hatch anywhere up to a year after they're dried out, after they're laid. The Aedes aegypti mosquitoes have been found in Los Angeles City, as well as in eastern parts of the county. The specific cities are listed in red with the bracket on the left-hand side of the slide. And the Aedes albopictus mosquitoes have been found in over 20 different cities in Los Angeles County, primarily in the San Gabriel Valley. The Aedes aegypti mosquitoes and the Aedes albopictus mosquitoes in Los Angeles are shown on this slide. The data come from the greater LA Mosquito and Vector Control District. And you can see there's a very small red number 1 that is kind of in West LA, just north of the 10. And that is the location of the residence of the Los Angeles City case. And you can see that fortunately she doesn't reside where they have found these mosquitoes, so that there would not be a risk that a mosquito could have bitten her, become infected, and then infect other people. But it still is critically important that we control the Aedes mosquito population, and that is a responsibility of the mosquito and vector control districts which do surveillance or trapping of these Aedes mosquitoes. They investigate complaints and do targeted treating with larvicides and adulticides to reduce the larvae and the adult mosquitoes. And there are some new technologies that they're looking at to control these mosquitoes. But a really critical factor is public education and the actions that people can take to reduce the risk. That includes identifying and reducing standing water around homes, and recognize that this water may be in very, very small containers. What's shown on the slide here are bottle caps. And you can see in that bottle cap on top with the yellow circle that there is a mosquito larva that's swimming around in just the very tiny amount of water in this bottle cap. And then, as I mentioned, vector control will come out if people complain about multiple bites occurring during the day. So what is the future course of Zika? Does it have pandemic potential? Remember that slide that I showed at the very beginning, which shows the range of the Aedes mosquitoes, and indeed, the virus does have the potential to spread to all of those areas. We do know that virus is increasing around South Central America, or Mexico and the Caribbean, and more countries outside the region also are likely to be affected. We also know that travel-associated cases will continue to increase. We still have, as I mentioned, many tests that are pending from the California Department of Public Health, or CDC. With other mosquito-borne diseases like dengue or chikungunya, we have seen some local transmission occurring in Florida and New York. There has not been local transmission occurring in Los Angeles, but because we have the mosquito vectors, it is a possibility. And so we need to be aware of that possibility and do everything we can in order to prevent the local spread of this infection. And just listed here are a number of website resources, because information is changing every day. Rather than telling you to look up this article or that article, really some of these websites are the best places to get the most up-to-date information. So thank you so much for asking me to come and talk about this with you, and I'd love to answer any questions you have.
Great, thank you. Are there any questions from the commissioners?
This Jimenez, is there anything pathognomonic about the rash or distinctive about the rash that Zika produces?
The rash is a maculopapular rash, so it's not particularly distinctive. It may occur on the body, on the extremities, so it's really not unique to this particular infection. The conjunctivitis is something that is more common with Zika than with the other viral mosquito-borne diseases that I had mentioned. And so the clinical symptoms that we look for are 2 or more of rash, fever, conjunctivitis, and joint pain. So somebody who has traveled to an affected country and has 2 or more of those 4 symptoms would be someone that we would be very concerned about.
And then the second question is, or just statement, was about people with ponds and mosquito-eating fish. I mean, I know the county is doing distribution of those.
Yeah, mosquito fish are really, really very effective at eating mosquito larvae. And so, when used in ponds, when used in uncared for swimming pools, they can be very effective. The problem is that when you're talking about a small amount of water that can be in a bottle cap, clearly that's not something you could also put a fish in. So I really think that there's a lot of education we need to do, and people need to be aware of the responsibility that they have and that the role they can play in keeping their neighborhoods safe.
And the county is distributing mosquito fish for free, I understand.
They are, yes.
The question I have is an embryologic one, if you would know, which is the virus capable of living in the chorion?
We don't know much about how long the virus may persist in a pregnant woman. And that's something we'll be looking at as more infants are born from infected mothers. We'll be getting samples from the amniotic fluid, from the placenta, from the cord blood, and just trying to better characterize what that risk is.
The reason I asked the question is because given the large number of people in LA County who do travel to some of those infected areas, given the CDC guidance that when they come back they shouldn't get pregnant for who knows how long, that's not really going to be so practical. So practicing obstetricians is going to have to really address that. And until we get more information, it might be prudent, given the 2-week incubation and 1-week infectivity, if we know that the chorion's not infected, that we can tell people, listen, if you want to get pregnant, then, abstain for 1 month until you come back. Then once you are pregnant, go back to using condoms until we learn more, which might be a prudent way to do it, but how do we say that without the data?
Right, and then the tricky part of making recommendations is perhaps not so much if the woman travels,
Right.
because we know that infection is
travels
not
with
chronic and that women will clear the infection quickly. But it's if the men travel, because as semen is in an immunologically protected space, the duration of virus in that fluid may be much longer.
Right.
Yeah.
Great. Any other questions? I have one question. Are you doing outreach to airports and people who are coming back from Zika-affected areas?
There is information at the airports. Yes, I think what we'd like to do is we'd like to reach people before they travel. And we'd like pregnant women to know about the risk and ideally to change their plans. Or if they do travel, or anyone who travels, to use good mosquito protection. And so, one of the things that we're always looking for is more advice about community partnerships and about better ways to get the word out. So this commission and the council, if there are ideas you have of better ways that we can get that information out to people, that would be really important. Currently, we're getting about 15 to 20 specimens for testing each day, but we estimate that
How many, excuse me?
about 15 to 20 per day, or 60 or so in a week. But we estimate that there are over 300 pregnant women who likely are traveling in any given week. So we're really getting specimens from a minority of those travelers. And so we do think that continuing to work to get the word out is really important.
Great. Thank you. Thank you so much for coming.
Thank you.
Thank you.
Okay, next we're going to move on to an overview on mental health in Los Angeles. Dr. Robin Kay, Acting Director for the Los Angeles County Department of Mental Health, and Dr. Irma Castaneda, Deputy Director, Emergency Outreach Bureau for the Los Angeles County Department of Mental Health. Thank you so much for coming.
Well, I want to thank the Commission for having us. We did not bring a PowerPoint. We thought we would just talk to you a little bit about the overview of the County Department of Mental Health, which is kind of a challenging thing to do. The Department of Mental Health is organized geographically into 8 different service areas throughout the County of Los Angeles, from Service Area 1, which is the Antelope Valley, 2, the San Fernando Valley, 3, which is the San Gabriel Pomona area, 4, which is metropolitan Los Angeles, the area that we're in right now, 5, the West Side, 6, South LA, 7, Southeast Los Angeles, and 8, which is Long Beach. In those areas, we offer services to all age groups: children, transition age youth or adolescents, adults, and older adults. And our scope is really broad. The County Department of Mental Health is charged with delivering what's called or referred to as specialty mental health services through our mental health plan agreement with the state of California. Each county is the entity that delivers those specialty mental health services for people, adults with serious mental illness, and children with serious emotional disorders. We offer those services through a network of community-based programs, residential treatment programs, fee-for-service hospital programs, and other more intensive programs delivered in locked settings. The Department of Mental Health is the public guardian for the County of Los Angeles. We're responsible for people, older adults generally, that are on probate conservatorships and adults who face civil commitment in order to receive assessment, evaluation, and treatment for their mental health needs. People generally come into contact with the department in two ways. They are searching for outpatient mental health services, and we've distributed to you information about how to access those services on a local level. And sometimes they come into contact with us because they have a mental health emergency. They may contact law enforcement and be put in contact with us through our law enforcement teams in Los Angeles City. We have a partnership with LAPD through our SMART teams, in the county through our MET teams with the Sheriff's Department. We have an 800 number, which is 24-hour-a-day, 7-day-a-week number, which is our access number. And I don't know how many of you carry iPhones, but we have an app. So if you go to your iPhone and you request the Profiles of Hope app, Profiles of Hope, that's actually one of the things that we've done to reduce stigma in Los Angeles. Is we developed a set of videos done by famous people who talk about their experiences with mental health and addiction. It's called Profiles of Health. The department's actually won several Emmys for that series. And so the app is called Profiles of Hope. And if you request that app, and I would encourage members of the commission to go ahead and order it. It's free. It'll put you in touch not only with the videos, but also with a way to access information about mental health services throughout the county. All you need to do is type in your zip code, and it will take you to all of the mental health services in your area. It also gives you information about resources related to emergency kinds of mental health services. So I'll stop with that because I know the commission probably has questions, and just ask Dr. Castaneda if she would like to say a few words.
I just wanted to mention that the Department of Mental Health also has a robust field response operations, and in that operational program we have 64 staff that 100% of their time is doing homeless outreach. So that's one team per service area, which is a team of 8 clinicians and other staff. We have another homeless program that does outreach for homeless in Service Area 4 and Service Area 6, which is South LA and the metropolitan area. And we have clinicians partnered with at least 24 law enforcement agencies in LA County. The biggest partnership is with LAPD, where we have 32 clinicians who partner with a law enforcement officer to respond to calls pretty much 20 hours a day, 7 days a week. And then for the very service-resistant individuals, we provide a very extensive array of outreach as well as engagement services. So the department also does a lot of community education through our various platforms. We have a mental health first aid training, for example, which trains different entities, either non-clinicians or the public. We've trained over 4,000 individuals who request that training. We also do trainings at various levels, and we have cards which we give to, for example, to law enforcement, and tips on how to engage with the mentally ill with our resources on the other side, whether it's crisis services or whether it's some of our clinic services by geographic area. So we have a robust public information effort, as well as field-based services which go to the client where the need is.
Okay, great. Do we have any questions from the commissioners?
Just want to say thank you. We actually, in my day job, we took advantage of the mental health first aid training. It was absolutely fabulous. I thought I heard somewhere, probably Facebook, so let me ask you guys. I thought I saw somewhere there's an app, a partnership between DMH and USC School of Social Work. Did I see that?
Oh, okay. So that's actually not an app. But I'm glad you asked the question, Commissioner. The Board of Supervisors last week approved a board letter for a contract, a pilot program actually, that introduced in collaboration with the UCLA School of Social Welfare. You know, we're kind of old-fashioned in the department. Most of the work that we do is one-on-one, or we work with families or groups. But the USC School of Social Welfare brought to us the idea that perhaps particularly for adolescents, it might actually be more age-appropriate if we offered mental health counseling using the internet, or using a platform, not the internet. But so they have furnished through a grant, they're furnishing a number of families with iPads, and they'll be doing treatment, mental health counseling, using that iPad application. So we'll see how it goes. There's a lot of interest in it. It's been picked up by the media all over the place. It's funny because we do a lot of things, but that one just caught everyone's attention. And we think that for adolescents, that it may be a valuable addition to the work that we do. Thanks for the question.
One of the things we hear repeatedly is that there are not adequate emergency beds for folks that have behavioral problems, mental illness. How can we address that? Because I think what Big County has like 26, I think, something in that order, and I probably that's one of the bigger ones. So how do you deal with that issue?
Well, it's important to know, and I wouldn't disagree with the concern, but it's important to know that the network of inpatient services that we pay for includes both the county hospitals,
right.
And actually LAC-USC's beds are located at Augustus F. Hawkins, which is on the campus of Martin Luther King
Right.
Hospital. There are also inpatient beds, psychiatric beds that the county runs at Harbor UCLA Medical Center and at
Right.
Oliveview Medical Center. But there's also a network, and I'm going to forget the number of hospitals, basically contracted private hospitals that have agreements with the department, and we reimburse them for the inpatient admissions. And that's actually a much larger network of inpatient programs, acute hospital beds, than what the county has in its own portfolio. One of the good things about the Affordable Care Act is that with the expansion of people that have that Medicaid benefit, it's been increasingly it's been easier for us to find beds for people in those private fee-for-service hospitals. But in addition to that, and I want to pay tribute to Dr. Griffith, who's sitting to your right, the department also has contracts with several what we call short-dwell Medi-Cal hospitals. Those are hospitals that have a different sort of legal structure that contract with the department for beds that we can use for clients that have no funding. So the county hospitals and those short-dwell hospitals are also for people that don't have that Medicaid benefit.
We do hear, or I do, and that the paramedics are often delayed at hospital finding a place to take folks, and of course the fallback is that if law enforcement does it, they might end up going to a jail rather than to a treatment facility. So it's still a bit of a dilemma, I believe.
It is a dilemma, and I have to say that one of the things that the department has done beginning in 2006 is the development of what we call mental health urgent care centers. Those are freestanding, 24/7 designated facilities that law enforcement can take people to if they suspect that the person has a mental health issue. People can walk in, and they have immediate access to medication evaluation and case management services, substance abuse services, as well as crisis counseling and group and family assistance. We currently have 5 mental health urgent care centers, one at Oliveview, one directly opposite the emergency room at LAC-USC, Big County Medical Center, one on the campus of Martin Luther King, one on the west side on Washington Boulevard near that old Brotman Hospital, and a small one in the Norwalk area. However, through funding that we've received from the state as well as Mental Health Services Act funding, we're in the process of adding 5 additional mental health urgent care centers that will come on board in the next year. One in the Antelope Valley that is a little not quite as firm as the other 4, which are located in, the other 3. We're bringing on 4. One in the Antelope Valley, one in the San Gabriel Pomona area, one in Long Beach, and one in the Harbor UCLA area. And the research that we've done does show that even when brought in by police, when we have the ability to attempt to stabilize people in an urgent care center that is community-based and equipped to address their mental health needs, we actually have more success in preventing people from going into a hospital than if those same individuals are brought to a psychiatric emergency room. So we're hoping that we can get out ahead of that hospital demand.
If I may, those centers can hold them up to not quite 24 hours or something like that. 23 hours and 59 minutes.
Exactly.
Yeah.
Exactly.
Okay.
And then we do have other locked and high acuity beds. We've got our intensive treatment beds. We do buy about 250 beds in the state hospital every year on a daily average. We have over 1,000 institution for mental disease beds. Those are locked treatment beds where people tend to stay about a year. So, we've got, high-level, longer-term locked residential treatment or hospital-based programs. We've also implemented a number of what we call IMD step-down or enriched residential facilities over the last several years. And those are facilities for people that don't need to be in locked settings, but do need some support 24/7 in order to be able to maintain themselves in the community. So it's quite a large portfolio, and we're always looking for opportunities to grow that portfolio because in a county as big as Los Angeles, the need is tremendous.
And your department is now taking responsibility for the mental health care in the jail facilities?
Well, we've always had that responsibility for about 2 decades or more.
Right.
However, in the fall, that responsibility will move from the Department of Mental Health to the Department of Health Services, along with the
part
jail,
of the
along with the jail
consolidation.
along with the jail medical services are also being consolidated.
So the jail medical services are going into the Department of Health Services?
Yes, and the mental health services will go as well.
And the mental health people, okay.
Yeah.
Previously, the mental health folks in the jail system were under your department?
Yes.
Not part of jail, not the sheriff's department?
Correct.
Component.
They still are until probably September of this year.
Okay, thank you.
Okay, any other questions?
Dr. Jimenez first, please.
Is there any plans or a pilot program for partnering with primary care? The hospitalized patients are the tip of the iceberg, and a lot of those are cared for in primary care offices, a lot of these patients.
So we actually, currently, the Department of Mental Health is co-located in many of the DHS comprehensive health centers and MACs. We have co-locations throughout the county. Previously, before the implementation of the Affordable Care Act, when the last 1115 waiver had the low-income health plan, we actually entered into specialty mental health contracts with federally qualified health centers to deliver specialty mental health services in those primary care settings. We trained their mental health staff in evidence-based practices for integrated care with primary care. There were some challenges that occurred when the LIP sunsetted and the program became a Medicaid program, because in California, federally qualified health centers, many of them currently have mental health as part of their bundled PPS rate. But I understand that there's legislation that's being proposed that would, again, allow us to look at the possibility of bringing some of those specialty mental health services under the Department of Mental Health in collaboration with us. And we think that's exciting. We want the state, however, to transfer the funding for it that they currently absorb to the county, so that the cost isn't just passed on to Los Angeles. So it is, and it's actually, I'm so glad you asked the question. It's a passion of mine. It's where I did my dissertation, and so I'm still hopeful all these years later that the value of integrated care will continue to grow and thrive.
Are there patient care-centered homes with integration like that, or?
Well, so the DHS facilities are all patient-centered homes.
Okay.
They have impaneled clients, and then we provide the specialty mental health services. I should also add that non-specialty services are provided by primary care providers specialty services are delivered through our department, and we're hopeful that we'll have a chance to continue to collaborate with primary care to expand those services.
Thank you.
Commissioner Shannon, I'm wondering, oh, I'm sorry.
Please.
Go ahead.
No, go ahead. You may ask it. Well, I have three, so out of respect for your time, I'll give them to you, and you get to pick one.
Okay.
And then the other two, I will take responsibility for following up electronically. How about that?
That's
Because we've
perfect.
kept you here a very long time, and you do important work, and I bet it starts early.
7 o'clock tomorrow morning.
Numero uno, love to know what we ought to emphasize for implementation within the two companion homeless strategy plans. They're really important. They matter a lot to us. We've spent a lot of time thinking about it, and we'd love your thoughts as to what we should lift up as our reporting process goes forward. There's a lot of strategy recommendations, I think 98 or something between the two of them. That's sort of question area number one. Number two, you touched on a moment ago, MHSA reform in Sacramento. What are things we ought to be asking for? There's been some interest here, meaning within City Hall, in trying to adjust the funding stream at some level. May not be able to be accomplished without going back to the voters, et cetera. There's some suggestions you have that we could underline there. And then the third area is sort of the prevention side within the schools. And what is the framework that needs to be strengthened so that these challenges are addressed at an earlier age and appropriate treatment is begun before it becomes a larger public health crisis. So three potential topics. There's a lot of important work. I will take just one here for the group, and then I'll make sure I share notes with you.
Okay, that would be fine, and I'll give you my phone number if you want to call and schedule a meeting. That would be fine too. So those are three really big questions. I'm going to take the last one, not because I think it's the most important, but it is very important, but only because I think in the time that we have, it may be the one
Fair
that
enough.
I can make the most headway on. So there are a couple of areas in terms of young children and school services that I want to emphasize. Three areas, really. A number of years ago, the County Department of Mental Health made a promise to any school in Los Angeles that wanted on-site or school-linked mental health services that we would arrange those services. So we have a huge initiative, not just the department's directly operated program, but operating through our contract agencies. We have over 123 legal entity, large contract agencies. Most of them serve children, and most of those that serve children deliver services in school-based settings. The department's philosophy over the last decade since the implementation of MHSA has been increasingly to deliver mental health services in the field whenever possible, not solely within our bricks and mortar clinics. And so schools constitute a very important place for us in the delivery of mental health services to young children and transition age youth. We work with LAUSD, we work with the other school districts throughout Los Angeles County, and actually Los Angeles Unified School District, in addition to receiving services from these 123 legal entities, they have a mental health contract with us in their own right. So they have the capacity to deliver their own mental health services, and that's a dissertation unto itself in terms of how that works. But you know, the city and the LAUSD, because you're taxing authorities, they have the ability to introduce resources that most of our contract agencies don't possess. So we deliver a broad range of mental health services in the schools, and we think that that's terribly, terribly important. All children go to school, and it's a wonderful place for us to work with school personnel to identify children that are in need and to address their needs in a way that's responsive to them. We have also, since about 2010, developed a prevention and early intervention program using Mental Health Services Act dollars that some folks say is second to no other place in the country. We have a system of trauma-informed care for young children, starting from children 0 to 5 who may be in Head Start programs, preschool programs, therapeutic nursery programs, and going all the way up with the delivery of evidence-based practices for different age groups. Lots of services focused on parents and parenting, and lots on the children themselves, including one evidence-based practice that was actually developed by LAUSD and is known throughout the country called CBITS. The one area that is coming and that I think you should watch is with our Mhsa Innovations program. Every 3 to 4 years, there's a component of the Mental Health Services Act that enables us to introduce new projects, new programs that we study. There's a requirement to do an evaluation of those programs. And this year, the stakeholders have prioritized the implementation of trauma-informed or trauma-involved practices, and they will. And so that solicitation will be coming later this year, and particularly for children, for young children and school-age children, it's going to focus on not just the treatment of trauma, because we have lots of evidence-based practices that treat trauma now. It will focus on educating communities on how to identify children and families that have suffered from trauma, how to recognize that they're experiencing trauma, how to talk to them about trauma, and how to make referrals for trauma treatment. And it will also help to educate people in the community, early childhood caregivers and preschool programs, on how to engineer classrooms in order to make sure that children that are suffering from trauma have their needs met in these classrooms rather than being expelled. I cannot tell you, as you probably are as frustrated as I am, in hearing stories about children as young as 3 who are being expelled from classroom settings because people believe that they're suffering from behavior disorders, but we know those behaviors are often the sequelae of traumatic experiences that child or his or her family have experienced. So that's coming later this year. So that's the...
I just wanted to mention that we have, under the Prevention Early Intervention Program, we got funding for a school threat assessment and response team, and they basically go into the schools, and it's any educational institution. It could be community colleges, could be the elementary schools or middle schools. And if a child is posing a targeted threat, for example, they have a hit list or they have a threatening note, then we go out and we provide, we do a threat assessment, a very thorough threat assessment, and we work with the school and their crisis team in order to try to avert any potential threat to the students, to the teachers, to the community, et cetera.
Great.
Great, thank you so much. Thank you for coming.
Sure.
Thank you very much.
I'm going to give you the cards that we use.
Yeah, that would be fantastic. Okay, now we will move on to public comment on item 1. Armando Herman.
Good evening. Just earlier today, we heard from Vision Zero as they had a discussion regarding data or so-called information. But they forgot to mention that under capital improvements, it was scumbag Jose Huizar and his redevelopment agencies who denied us public access on the corridor of Soto Street along Cesar Chavez, as far down as Lorena, as far up to State. There was money allocated for that asshole to fix the sidewalks. But the douchebag decided to use the redevelopment money for his own personal gain. Fuck you, Jose Huizar, for that. And once again, capital improvements is not about exploring whether voters want to boost funding. It's whether or not we ask for more tax increases, assholes, or whether or not bonds and measures will be allocated to repair and fix our fucking sidewalks and streets. As I waited almost 15 years off of Soto, Corridor, and Marengo. No curb cuts, no ramps, but yet Vision Zero gives this presentation that our local government is taking full responsibility under the Woltz versus Los Angeles. As I came in earlier prior to this meeting, there was a meeting going on. And in that meeting, they had a discussion about sidewalks and streets, according to Paul Krikorian. but none of us were involved. He denied my public comment card, the douchebag, and on top of that, I'm sure there could have been some representation by the public, but I assure you not, there was not. That's why I have to use offensive language to get the attention of those local officials. Fuck you.
Wayne Spindler?
This your boy, Lil Boosie Badass. Yeah, when I was 12, turn me against this. Take me to my first funeral. Now I'm a big law. My daddy called him P. I never forget. He went to jail on Highland Road for trying to peace. Hit my auntie Trina though, looking for my cousin. Looked at me cross the street and said, "Boy, you ugly." Made it happen. That was my first run-in with them busters. Was stupid, roughed me up 'cause I told him motherfucker. Got over, got worse. My hustle got deadly. Running and ducking from that dirty bitch, Don Kelly. I was cool, you can catch me with my two. Smashing in my mag from the red, white, and blue. They asked me for money, try to bribe me, no. They let the dogs eat me up all by my fucking nuts. Don't give a fuck, nigga, freedom or jail. I want all bitches. Wait, bang. Narcotics, fuck 'em. Feds, fuck 'em. DA, fuck 'em. We don't need you bitches on our street. Say with me, fuck the police, fuck the police. Without that badge, you a bitch in the head, nigga. Fuck the police, fuck the police. Without that badge, you a bitch in the head, nigga. Fuck the police, fuck the police. Come search this bitch 'cause I don't do weight 'cause I'm too straight and y'all little bitches a little too late. Cuff me up in front of my kids, I look them all in their face. Walk me out like I'm a killer, scared the fuck out my neighbor. Tell me they don't put a pen and paper on the table and told me, give us some names so you can leave this bitch. I can't believe this shit. What in the hell? If that's my only way out, the nigga show me myself. Look, tell nigga stop. I sit here till I rot. For all that, I could have been a bitch ass cop. Yeah, boo, I got they hit me for a few thousand. But you dirty bitches, I'm ballin', I ain't missing at all. Soon as I got back to the house, I went and opened the pound and counted out 700. So much shit ain't get found.
Fuck this commission.
Okay, moving on to item 2, items for future discussion. Does anyone have any future agenda items?
As previously requested, can we have the county and the city CEO talk about the homeless plan? Thank you.
Anything else?
Forward a discussion item and hopefully action to use some of the remaining balance in the City Health Commission Trust Fund to potentially bring on board at least some part-time help to complete some of our analytical tasks as prescribed in the ordinance, and have been talking to a number of folks to get some input about how to most efficiently and inexpensively do that, and I look forward to trying to bring a recommendation for everyone's consideration in April in terms of a small scope of work and some estimate as to what that might cost and how we could get that conducted to move forward and support the work of the working groups and of to complete the objectives. So that's a very long statement that will be shortened into a tight agenda item for April.
Great. Any other agenda items that anyone would like to bring forward now? Okay, great. So we'll move on to public comment on future agenda items. Armando Herman.
Future discussion be talked about regarding capital improvements, how necessary and functional and measurable they can be, so that we're not leading our society into an issue where it comes to leading a cause of death. You create the cause of death in our streets because you don't amplify the real problem on the war on homelessness. You don't take your vision and zero in on the real problems, why redevelopment has crushed our society, our social economic society where people are left in the street homeless. Exploring whether or not voters want to fucking boost funding through more fucking tax increases or fucking bond measures. I say fuck that shit. It needs to stop. Local government needs to get a grip on the real issues, the war on homelessness. Because none of us want to live on the street. None of us want to be deprived of a home. None of us want to live anywhere else but when we're happy. And if we're not happy, then we're in a fucking depressed mood. And that fucking mood makes a lot of us fucking mad. So these intensifiers of using the fuck word is a very fucking element of a fucking discussion. Because all it is an intensifier to the mood you put us in. I've been here since 4:30 this afternoon, and I'm only speaking on 4 fucking minutes so far. So fuck the police, fuck local government, and fuck those who don't listen to the public. Take public concern to the most fullest, appropriate manner that is acceptable to hear us today. Measure us with dignity and without the oppressive mood you put us in.
Okay, Wayne Spindler.
Prosecuting attorneys are MC Ren, Ice Cube, and Easy motherfucking E. Order. Ice Cube, take the motherfucking stand. Do you swear to tell the truth, the whole truth, and nothing but the truth, so help your black ass? Goddamn right. Won't you tell everybody what the fuck you gotta say? Fuck the police coming straight from the underground. A young nigga got it bad cause I'm brown. And not the other color, so police think they have the authority to kill a minority. Fuck that shit cause I ain't the one for a punk motherfucker with a badge and a gun to be beaten on. And thrown in jail, we can go toe to toe in the middle of a cell. Fucking with me cause I'm a teenager with a little bit of gold and a pager. Searching my car, looking for the product, thinking every nigga is selling narcotics. You rather see me in the pen than me and Lorenzo rolling in a benzo. Be the police out of shape, and when I finish, bring the yellow tape to tape off the scene of the slaughter. Still getting swole off bread and water. I don't know if they fags or what. Search a nigga down and grabbing his nuts, and on the other hand, without a gun they can't get none. But don't let it be a black and a white one, cause they'll slam you down to the street top. Black police showing out for the white cop. Ice Cube will swarm on any motherfucker in the blue uniform. Just cause I'm from the CPT, punk police are afraid of me, huh? A young nigga on the warpath, and when I finish, it's gonna be a bloodbath of cops dying in LA. Yo, Dre, I got something to say.
Fuck the police! Fuck the police!
Too fucking bad. You lose again, motherfuckers. Fuck the police.
Okay, now we'll move to public comment on non-agendized items. Adam Cohen.
Good evening. My name is Adam Cohen. I'm a public health consultant for AIDS Healthcare Foundation. I won't even need 2 minutes. I just want to bring up that I love the discussions that were discussed, the topics that were discussed today regarding homelessness. Not only is there a growing number of people who are homeless, but now we have waves of LA cities seizing their property, and I think that is a serious, serious public health issue, because forcing people who are homeless to constantly be on the move may have serious health implications, not only for them, but for LA City as a whole. I'm not sure what LA City is trying to accomplish by taking away their property, but that's not how you address homelessness. I also want to speak about the rising rates of sexually transmitted infections in Los Angeles County and Los Angeles City. LA County has some of the most cases and the highest rates of chlamydia, gonorrhea, and syphilis in California and in the nation. And I think that is definitely something that should be addressed in not only LA County, but especially in LA City. And lastly, I just want to speak that I'm very happy that the reports are kind of moving forward regarding LA City's Health Commission responsibilities, and I want to just commend the commissioners for organizing those efforts and moving forward. Thank you very much.
Thank you. Armando Herman.
So our special meeting, Public Works and Gang Reduction Committee, also Budget and Finance Committee. I'm going to read you from their agenda. Motion of Room Bloomfield and Busquiado relative to request city attorney of the report for feasible and using funds from the Woods versus the City of Los Angeles settlement agreement for the above proposed sidewalk repair pilot program. Well, here, Mr. Weezar, this is what you said in the LA Times, dated Wednesday, February 10th, 2016. In effort, you said, Mr. Weezar, that I would ensure that services were provided throughout the city rather than concentrated in certain areas. Well, you're a racist because the area is here, the city of Los Angeles, where we fight on a day-to-day basis of becoming the next war on homelessness. How dare you? How dare you? This is not going to be a cheap fix. Taking it right out of the newspaper. Rather, your rules hold possible signs of skepticism over the executive administration authority here in City Council to fuck with us. We, the homeless, are members of the City of Los Angeles, so much so to say, and brought out in this article saying that it designates $11 million for short-term housing, such as shelters and group homes for people coming out of county jails. Well, listen, a-holes, as Sheila Keel put it, assholes. We need to approve on housing. We need to get the money fluctuating on behalf of homeless peoples, African Americans, minority, Hispanic, and Asian who fit that small population. We see more blacks being homeless due to the gentrification that you caused, Herb Wesson, you little midget, sitting up there on the podium.
Wayne Spindler.
How many fucking reports? 3 reports, 4 reports, 5 reports, and you get 2 fucking minutes to speak on 5 reports? You know better than Herb Wesson. You know better than that little fucking gangster. That's all you become, is that little fucking gangster. But we don't have to worry about it, because all you got to do is get arrested by the LAPD and fucked with enough times to get your claims under control. 42 USC 1983, etc., etc. So now I'll do what everybody else does. I'll sue the fucking city in federal court. That's what I'll do. I got to do it like everybody else. Everybody else has got to sue the fucking city. If you're listening to this, don't fuck around. Sue the city. Just file a pre-suit notice before you walk into a meeting. And that's what you got to do. All the Jews are going to be dead. This is why.
I lived for 1 year in Saudi Arabia, and I asked any Muslim in America or the world, you are taught to hate Jews and to destroy Jews and to destroy Israel. You scumbag, you Sheila Keel, you anti-Semitic scumbag. Listen, you asshole. I am a Jew. My mother was a Jew. I don't give a shit. You're a self-made Jew. I have to talk.
Yeah, that's right. There's the pig, Hilda Solis, that fucking cunt wants order. She's going to get order when I shove a fucking big fat federal lawsuit up her fat fucking Latina cunt, the pinche cula.
Okay, commissioners, I'd like to entertain a motion to adjourn. Second. Okay, all in favor? Aye. All opposed? Thank you so much, and we'll see you next month.